This is a really good opportunity for more audience participation and interaction, because I've got nothing much to say, which can't be true because usually I can rabbit on. So I was very hopeful, as she did, that Kerry would really blitz through the kind of whole of the framework. Sometimes it is a little difficult to grasp what the totality of this is. I've been on record as saying this is kind of like fresh air in a can, and now being sold, it's kind of like a little bit like that. But as we well know, nursing and medicine seem to have lost something about basic care that as professions we should have and we should be delivering. And it's actually difficult to define what has been missed, although we hear lots and lots of complaints and we can compare good and bad experiences within health. And boy, we've got a lot of bad ones, have we not? And if we do it ourselves through ED or whatever, it really starts to get the steam rising. So it's intriguing, and how can we get to a better place knowing that we're working with the people that we are, and the different teams that we've got, and the different political directives that we have, and the lack of finance that we have. It's a whole complex bundle, but do better we must, and the challenges are getting increasingly severe. So, what is gold standards in New Zealand, and who's had a tickle at what? So ProCare in Auckland is probably the group that has had the most sort of tinkering around with gold standards, and Professor Rod McLeod up there went pretty far in terms of looking to see if they could do a whole of gold standards framework, at least in primary care, and really fell foul of the funding aspects. Mid-Central Health have developed what's called a Palliative Care Partnership, which is really, you could say, is founded on some of the principles of the gold standards framework. It sought to remove cost as a barrier to general practitioner and practice nurse engagement. It didn't go as far as gold standards have gone, but would be quite easy to tweak in that regard and make it a GSF-esque program, but it would still not be, or could not be, monikered as gold standards framework. Pegasus and Christchurch have also had a long-standing, partially funded scheme for general practice involving visits to their patients. Auckland ProCare have reinvented what they have done and have something quite similar to the Palliative Care Partnership, but morphed in a slightly different form. And I think the sort of sums of money that different groups are doing are all quite similar, and it amounts to about $400 per palliative care patient, divvied up in different ways. Some just saying a nominal number of home visits at a certain cost. Others, like Mid-Central Health, have itemised a whole number of things that practice nurses can gain access to, GPs gain access to, and hopefully the patient wins. Hawke's Bay have looked at the Palliative Care Partnership model, and they have applied a similar and again somewhat morphed Palliative Care Partnership model. The Wairarapa, which doesn't have specialist palliative care inherent in the Wairarapa, have taken some of the aspects of the Palliative Care Partnership and worked with Tiamanga Hospice as their specialist provider and formed an integrated service that's predominantly community-based. And it had been the case that some general practice teams up and down the country were utilising a funding source called Care Plus, which is really for chronic care conditions, and I think the bean counters have managed to put a spotlight on that, and I believe that has been axed for palliative care. A few nods around the room. So we're increasingly in need of something better around palliative care. What does that say? Oh, thank you, I can see it there. Right. So I don't think any of the the groups around the country have gone as far as actually forming registers, which is one of the key components of the palliative care, the primary care approach and gold standards framework, which, as Kerry has implied, works variably in the UK. So I think some GPs will form a register, maybe a limited register, and they say they're doing it in terms of their accreditation status. They may not be having the interdisciplinary team meeting, say perhaps once a month, on site, where, if you like, the interdisciplinary specialist team is coming on site to primary care on a reasonably regular basis, and the team then looks at the register of patients, discusses that, gives advice, changes the status of the patient depending on the need, and that would provide a useful means of agreeing referral to specialist palliative care services and all the bells and whistles, or just advising the general practice team to keep the patient in the community, but just do this or that in the way of advice. And indeed, one could see that applying to chronic care settings in primary care, forming different registers of at-risk. And for me, but this is discussion for later around advanced care planning, what a lovely place and time for advanced care planning to be brought up in terms of in the general practice setting, and how it's done is also up for some discussion and debate. But I've seen a very simple model used in the UK, whereby from general practice a very simple plan is made by patient and family, recorded, and then brought out and confronting ED or hospital teams as to what the patient wants. So at the present time, Mid-Central Health and Christchurch and West Coast are both interested in expanding a sort of gold standards framework type approach, and both have made a bit of an entree to the district health boards regarding what this might look like, and are certainly keen to do that. Both of these sites have got interested GPs, and remembering what Kerry said, this is quite critical. This is not about the ministry or the minister imposing something, or Simon in this locality saying this is the way GPs have got to work, or aged care's got to work. It's more about how you raise the sort of interest, and this meeting today is a very exciting one, a tremendous audience here. And I think if there's a groundswell of desire for something like this, that would be exceptionally helpful. And both the sites who are interested would like to see aged care integrated into this. Presently, I'm not sure if we can do the whole system change and involve the hospital, but maybe elements of involving the hospital will be crucial, particularly that ED. But it's quite a big thing to change the world. So champions are being looked for, absolutely. Is gold standards framework the way forward? So thinking of New Zealand, fairly parochial, divvied into 20 devolved health system units, where we're being told to get it together and form alliances, and we won't have a bar of Wanganui won't have a bar of us. If you put in a mandate, it's not going to be a very, very, neighbourly or collaborative engagement. So how do you make that sort of stuff happen? And I think in our heart of hearts, we know that something has to happen for sure. And it would be jolly good if it happened, particularly in community and particularly in primary care, where the obvious things are being said, and the power brokers that be at the moment need to rethink themselves greatly and start to see the integrity of the patient being at the centre of our changes, and how important that is to get a better outcome, particularly with that tsunami effect, which is no different in New Zealand than it is in the UK. So, gold standards framework has a cost. So there's intellectual property, which is reasonable to pay something for, I would suggest. However, much more importantly, are the tools, the training tools, educational tools, and the metrics which wrap around this. And boy, they've now had 11 years of developing all of that, and they're really super duper. Haven't had a feel for all of them, because the more they give out, the more we'll pinch, you see. So it's a little bit of, you can't find out about it all. But the more I see, the more I realize just what a wraparound it is. And as Kerry has said, if you think about the time taken for training and development of tools, actually it's almost certainly extremely cost effective. What's that bottom thing? How does cross? Yeah, right. So this is more about, again, how do you do it? Do you do it from top down? Do you do it from bottom up? Do you do a mix of both? And I suspect it's somewhere in the mix of both. And certainly, it's possible to work on region-wide application of GSF. Probably that's a better way than trying to drive it from nationally. So model sites probably first. I say 2 sites are looking at it. What's the cost, Kevin? Per GP practice in the UK, £700. So at the moment it's roughly doubling that, but 5 years ago it was tripling that. So that's the sort of costs for GP practice. GP practices in the UK tend to be larger, so bear that in mind. And £25 per aged care bed. So initially you think, it's quite a shell out. I would say that all of that is highly negotiable, and it is at the moment being negotiated. I've sent something back just as a punt to try and form some discussion, and it is quite a punt. It's definitely less than 50% of that, and maybe targeted around general practice being different sizes. And it's also about the fact that we'll need to customise it for a New Zealand environment, and that will involve some of our facilitating time. We will need to see, if we are going to invest in it, whether it requires facilitation by FTE, and I suspect it will, particularly if you're looking at facilitating advanced care planning as well. So those discussions are happening. Gold standards framework haven't quite got their head around international contracting and what it looks like in different countries. And the fact is that all of these countries mentioned have got very different systems, extremely different systems. Northern Tasmania, which is probably closest to home, Robin Brogan is rolling out a program there in aged care. Seems to be going really well. The aged care facilities view this as a very cost-effective way to do things, and I think they're paying UK prices.